Cranial nerve 1 is a special sensory nerve. It presents with anosmia. A lot of patients actually do not notice that they cannot smell unless they have a profession like a cook, that they notice that their smell is degraded. What we have is we have the olfactory bulb right above the cribriform plate, and then we have small fibers going through the cribriform plate into the superior nasal cavity. From the posterior aspect of the olfactory bulb, there are two tracts, the lateral olfactory tracts and the medial olfactory tracts. Both eventually end up in the olfactory projection area, which is in the uncus. The uncus is then relaying information to the hippocampus, which serves as the olfactory memory. On imaging, when we look at the olfactory bulb, we would like to do coronal T2 weighted images. This is the best you can always see them. And they are typically ovoid in shape. The shape changes a little bit depending on how your intracranial fossa is developed. Sometimes you will have a shallow fovea ethmoidalis and the olfactory groove, or sometimes it will be more steep, and because of that, it might be more horizontal or more vertical in orientation. So let us look at some pathology. This is a child that came for evaluation of developmental delay, and the first thing that you see is a large arachnoid cyst that is displacing the brain parenchyma. But when you're looking carefully, you also notice that there are no olfactory bulbs on both sides. In the anterior portion, in the posterior portion, you have a small rudimentary bulb on the left side, nothing on the right side. When you look at the sagittal images, you also identify that the pituitary gland is really small, and the constellation of findings of the olfactory bulb, agenesis with very small pituitary gland, is consistent with Kalman syndrome. Many times we see a non-existent or very small olfactory bulb on one or both sides, and many times we don't have any additional associated abnormalities with it, and this could be congenital in nature. However, often it will be also related to infection causing atrophy of the olfactory bulb. Often this is a viral infection such as simple cold that is translated to the olfactory bulb itself and causes problems with smell sensation afterwards. However, when you see encephalomalacia associated with it in the infrafrontal lobes, where you see barely any bulbs, this is typically post-traumatic in nature, which is one of the most common etiologies for anosmia in our adult patient population. Here we have a patient who has a large mass filling up the entire nasal cavity. This mass alone, because it prevents the smell going to the roof of the nasal cavity, could prevent that we are smelling correctly. However, what you notice also on the MRI is that there is intracranial extension and that the olfactory bulb is actually affected. We have the normal olfactory bulb on the left side. We cannot identify it on the right side. This lesion shows marked enhancement following contrast administration. This is a non-specific finding. This could be certainly a squamous cell carcinoma arising in the nasal cavity or ethmoid air cells. However, when you see the characteristic cystic structure superiorly towards the brain parenchyma, as demonstrated in this particular patient, your diagnosis of esthesioneuroblastoma would be the most appropriate, because squamous cell carcinoma does not have the tendency to have those cysts towards the intracranial structures. So what are the key points for cranial nerve 1? Coronal T2 weighted images are your money maker. So here you can best determine the size of the olfactory bulbs, or if there is involvement of the cranial nerve 1, as demonstrated in the last few cases, where you have a big nasal cavity mass with involvement intracranially. You often see atrophy, which can be due to prior infection or to post-traumatic disorders. And last but not least, occasionally you will see esthesioneuroblastoma as the most common primary neoplasm of the olfactory bulb. In those cases, you characteristically see the cyst along the intracranial edge. Let us move on now to cranial nerve 2. We will talk first about anatomy. It will be transmitting the information from the retina to the optic cortex. And the temporal retina, the fibers from it are extending in the lateral aspect of the optic nerve. They are not decussating in the optic chiasm, and they are extending then posteriorly to the optic tract. The nasal retina, the fibers are projecting in the medial optic nerve on each side. They are crossing at the level of the optic chiasm. Subsequently, both of those cross and non-cross fibers on each side continue in the optic tracts to relay in the lateral geniculate body within the thalamus, and then through the radiation, optic radiation in the temporal lobe and the parietal lobe to the visual cortex, which is located in the occipital lobe on each side. Since we are talking about cranial nerves, we will be stopping just posterior to the optic chiasm in our differential diagnostic considerations. So when we are looking at the normal images of the optic nerve, the optic nerve will always assume the signal intensity of white matter because it is extension of the white matter into the orbits. What I want to emphasize is that there is small amount of CSF surrounding the optic nerve, and then we have the meninges that contain the CSF. So I always pound on my residents to call it optic nerve sheath complex, so they are better evaluating, is this a lesion that is originating from the optic nerve? Is it a lesion originating from the CSF or involving the CSF space, or is it a lesion that is involving the meninges themselves? Then as we move posteriorly, we're going to the optic canals, where we start losing the CSF surrounding it. So on one side you see it very well, on the other side it's starting to be lost. And then eventually we're ending up in the optic chiasm in the suprastellar cistern. Here we have your pituitary gland inferiorly, and laterally you have the cavernous sinuses with the internal carotid artery. So as we have involvement of the optic nerves, we can have scotomas that involve either one optic nerve or both optic nerves, depending on what kind of disease process you're dealing with and how extensive the disease process is. And we have a broad variety of causes ranging from congenital over inflammatory to vascular diseases. So let us look at these separately. So in this particular patient, we see that there is a lot of CSF in the optic nerve sheath complex. We can barely identify any optic nerve on the right. We see a little bit more than on the left. There's barely any visible optic chiasm. Notice also that there is lack of the septum pellucidum, and this is a characteristic appearance of septo-optic dysplasia. This is a severe case of optic nerve atrophy. Sometimes the optic nerve will be just slightly decreased in size. Here we have another congenital abnormality where we have a saccular extension through the region of the sphenoid sinus into the nasopharynx that drags the optic chiasm and the optic nerves with it. This was an encephalocele that was congenital in nature. Here we have a CT examination on two different patients, and when you're looking at the CT on the soft tissue windows, you see the continuation of the optic nerve with the optic nerve disc junction. On the right side, however, there is disruption because of avulsion of the optic nerve due to traumatic injury. In this particular patient, we have many fractures in the ethmoid air cell area, but notice also that there is a fracture extending through the optic canal, placing the patient at risk for optic nerve injury, which could be a transection of the optic nerve or could be just a hematoma compressing the optic nerve. So this will be critical to mention to the ophthalmologist because they might attempt a decompressive surgery. Here we have a classic extensive enhancement of the optic nerves bilaterally that is quite diffuse in nature and affects the majority of the intraorbital segments of the optic nerve, a little bit of inflammatory changes around it. That's very commonly associated with optic neuritis, and when you see additional lesions in the corpus callosum or in the spinal cord, your diagnosis of optic neuritis related to MS can be established. However, when you see just enhancement at the optic nerve disc junction that is bulging into the globe itself, this is not characteristic of optic neuritis. Optic neuritis does not usually cause this mesh-like appearance and is usually not that localized in nature. Whenever you see that, think of cat scratch disease. It really likes the optic nerve disc junction. Sometimes it will be less bulging. If you see bilateral bulging with usually not as much enhancement and dilatation of the arachnoid spaces around the optic nerve, think about it, could this be idiopathic intracranial hypertension reflected into the orbits and causing potentially papillary edema and visual loss? Here we have a patient where we have bilateral enlargement of the optic nerves, left greater than right. There's no significant enhancement associated with it. So your differential diagnosis becomes a little bit narrowed, in particular when you're seeing T2 hyperintensities in deep gray matter or other structures in the brain parenchyma, this will be the diagnosis of optic nerve glioma in NF1. However, if you see the same picture with marked enhancement, your differential diagnosis is much broader. Here you will have to consider sarcoidosis, in particular in middle-aged females. Lymphoma would be another option, or sometimes acute radiation-induced optic neuritis will have marked enlargement of the optic nerve with profound enhancement in the initial phase with atrophy in the subsequent phase. In contrast to this patient, we have here the optic nerve being severely compressed by an extrinsic lesion. So this is where it comes into play, the importance to differentiate, is it intrinsic to the nerve or is it extrinsic to the nerve itself? So this is a circumferential lesion. In this particular patient, this was a meningioma. But you can also consider carcinomatosis along the optic nerve sheath complex with filling up the arachnoid space around the optic nerve itself. It could be, of course, also sarcoidosis or lymphoma itself. Usually leptomeningeal carcinomatosis is not as bulky in appearance. If at all, you will have the smooth or slightly nodular appearance, but not as compressive, causing such a compressive effect upon the optic nerve itself. And then last but not least, I want to touch base on infarction. This is a diffusion-weighted image which shows restricted diffusion in the posterior aspect of the optic nerve on the right side. You see additional involvement in the superior cerebellum. Notice on the T2-weighted images that there is lack of flow void when compared to the contrast side. So this was acute optic nerve infarction. Usually we don't see it in that stage. Typically we see it in the chronic phases where you have atrophy of the optic nerve, and it's typically a diagnosis of exclusion in elderly patients. Let us move on now to the optic chiasm. The most classic one is the bitemporal scotomas, typically related to suprasellar mass, such as pituitary gland adenoma and craniopharyngioma being the most common lesions. However, you can sometimes have lateral or superior compressive lesions, such as caused by aneurysm, in particular of internal carotid artery, or when you have tortuosity of the internal carotid artery or intercommunicating artery, or ACA. So here we have our classic pituitary gland macroadenoma extending into the suprasellar cistern, causing marked displacement and flattening of the optic chiasm. So you will be expecting here the bitemporal heminopsia in this particular patient. Here we have a similar patient, but the appearance of the lesion is different. It's cystic in appearance. Again, it superiorly displaces the optic nerve and markedly flattens it. But when you look on the post-contrasted T1 sagittal images, you notice that the pituitary gland is displaced inferiorly, that you have lobulations with enhancement and some nodularity. This is more consistent with a craniopharyngioma. On CT, you typically see some small calcifications associated with it. And then some vascular compression. Here we have the ACA that is impinging upon the chiasm from superiorly and can result in small scotomas. Usually they will be inferiorly located. Or here we have a large internal carotid artery aneurysm that is impinging upon the lateral aspect of the optic chiasm and causing a more unusual nasal scotoma. So what are the key points for cranial nerve 2? Type of scotoma directs your view to the lesion location. Optic neuritis is by far the most common cause in younger patients. Typically it will be related to multiple sclerosis and occasionally to neuromyelitis optica, in particular when you have bilateral involvement of the optic nerves and you have extensive lesion involvement in the cervical spine. And then think of optic nerve ischemia, which is the most common cause in elderly patients. Let us move on now to cranial nerve 3, 4, and 6. The classic symptom is diplopia with disconjugated gaze, meaning that in some direction the eyes will be moving not congruent with each other, and this is what the typical appearance is to the patient, that they are not, that they have two images that are offset to each other. Remember that cranial nerve 3 will also cause ptosis, and this is often much easier identified than necessarily the disconjugated gaze. So the superior oblique muscle is supplied by cranial nerve 4. The lateral rectus muscle is supplied by cranial nerve 6. All other extraocular cranial nerves, muscles, all other extraocular muscles, including the levator palpebral muscle, are supplied by cranial nerve 3. So this is a drawing that I just want to point out one important thing on, is that those cranial nerves are really in close proximity to each other at the cavernous sinus level and the oral apex. Otherwise, they have different locations, and because of that, typically we do not have involvement of all those nerves together. So let us start with cranial nerve 3. It has multiple nuclei in the posterior midbrain that is located anterior to the sylvian aqueduct. The motor component is medially located and supplies all recti muscles except the lateral, as well as the inferior oblique muscle and the levator palpebrae muscle. In addition, we have a parasympathetic nucleus, the Edinger-Westphal nucleus, that is demarcated here in green, who relays in the ciliary ganglion to supply the sphincter muscle. And this is important because you will have abnormal pupillary reflex with it. So when you're looking at our heavy T2 weighted images, we can see the cranial nerve 3 coming off in the interpeduncular fossa and extending in the basal cistern to the superior aspect of the cavernous sinuses. In its course, it will be coursing between the PCA and the superior cerebellar artery. So this is our cranial nerve 3. And then it will be laying in the dural duplication along the lateral wall of the cavernous sinus as the most superior cranial nerve. What is really important to notice also is that it runs parallel to the posterior communicating artery that is not always present, but when it's present, it's predisposed to develop aneurysm at its origin, and these aneurysms tend to impinge upon the cranial nerve 3. What is interesting about the cranial nerve 3 is that the parasympathetic fibers like to be in the superior aspect of the nerve itself. So because of that, any PCAM aneurysm will be primarily impinging upon the parasympathetic fibers and will initially just present with an abnormal pupillary reflex. So let us look at some pathology. We can divide this in a central segment, meaning that it will be in the midbrain and the root exit zone. And we see here edema on the FLAIR-weighted images with areas of restricted diffusion where we would anticipate to be the nucleus and the exit zone itself. So that's consistent with acute infarction. Here we have another case where we have spontaneously increased T1 signal intensity at the root and exit zone of cranial nerve 3 that shows hemosiderin deposition and almost popcorn-like appearance on the MRI source images that are gradient images. So because of that, this is consistent with a cavernoma. As we move to the cisternal segment, our PCAM aneurysm will be the most common cause of cranial nerve 3 palsy. You can see it here nicely in the sagittal plane and an axial plane. Here again, remember that it originates at the origin of the posterior communicating artery and will be impinging the parasympathetic fibers first. In addition, don't forget that ankle herniation can hit cranial nerve 3 as our ankles will be displaced medially. You see it here, cranial nerve 3 will be more and more approached and potentially displaced. This is your normal position of cranial nerve 3 on the contralateral side, and notice the difference in distance between the brain parenchyma on the normal side in comparison to the abnormal side. So you can imagine as the mass is growing, this cranial nerve 3 will be more and more impinged. And when you look at cisternal and cavernous segments, we have here a patient that has slightly enlarged cranial nerve 3 and shows marked enhancement in the cisternal segment as well as cavernous segment when you compare it to the contralateral side. This patient had acute onset of it, resolved within a few weeks. This is consistent with neuritis. In contrast, you see here enlargement of the cranial nerve 3 that is markedly bigger, looks more tumor-like in appearance. So here, your neuroma would be an option, schwannoma, or lymphoma, as this was in this case. You can look at the diffusion-weighted sequences and see if you can determine the restricted diffusion in that segment that will help you to narrow down the differential diagnosis. Moving out now to cranial nerve 4, which has paired nuclei inferior to the colliculus, so it will be also in the posterior midbrain as demonstrated here. This will be lateral to cranial nerve 3 nuclei. It decussates on the posterior aspect of the midbrain, posterior to the sylvian aqueduct, and it's the only nerve that exits the midbrain posteriorly. So it has a long course in the paramesencephalic cistern where it likes to be adjacent to the tentorial edge, and because of that, it's often very hard to see. The problem with it is depending where you have the lesion, it could be ipsilateral or contralateral. So if it is anterior to the decussation, it will be contralateral manifestation. If it's posterior to the decussation, it will be ipsilateral to the lesion. So here's the typical appearance on the heavy T2 weighted images because it joins the tentorial edge really quickly, as demonstrated here in the drawing. So it's inseparable from the tentorial edge. It will be going like cranial nerve 3 to the duoduplication in the lateral wall of the cavernous sinus and will be lying just inferior to cranial nerve 3. And here we have some pathology, again, separated by central segment. We have increased T2 signal intensity affecting the entire posterior aspect of the midbrain, left greater than right. So I would expect the cranial nerve 3 and 4 will be here involved, and it will be ipsilateral. And since we are hitting also the decussation, it will be contralateral. This is a moot point because we have bilateral involvement. This lesion did not show any enhancement, and this was a low-grade glioma. In contrast to this lesion, we have increased T2 signal intensity in the posterior midbrain and posterior pons with focal areas of hemosiderin and blood deposition. This was related to traumatic concussion or contusion that was caused by impingement of the midbrain and pons junction against the tentorial edge, where the cranial nerve 4 would be coming out as well. Here we have a patient where on the T2 you might completely miss it, but hopefully on the post-contrasted T1 weighted images you notice an enhancing lesion in the perimesocephalic segment of cranial nerve 4, and this was chronic in nature because we can see atrophy of the superior oblique muscle, so it will show you the acuity of the lesion, and this was consistent with the schwannoma. We have followed this patient for years and has barely changed over time. Let us move now to cranial nerve 6. That's the lowest nucleus in the pons itself, related to cranial nerve 3, 4, and 6. It's located in the posterior pons where the facial colliculus is, and actually the internal genu of the facial nerve is draping around the nucleus of cranial nerve 6. So this is what is forming the facial colliculus. Then the fibers are extending anteriorly to exit at the pontomedullary junction, medial to the cranial nerve 7. So what is really important about this anatomic structure is that often if you have a lesion located in the posterior pons, you will have both cranial nerve involved, cranial nerve 7 and 6. So that pathology directs your view right away to that region. Subsequently, the cranial nerve 6 has a steep course through the prepontine cistern before it enters the petrous apex at the Dorales canal. It is very firmly affixed at this level, and any translational forces inferiorly will kink it. Here in particular, your tonsillar herniation and transitory herniation will be playing a role because that kinking can cause cranial nerve 6 palsy. At the same time, any bony lesions in the petrous apex may cause cranial nerve 6 palsy as well. So in the volumetric T2 weighted images, I reconstructed them so that you can see the entire course of cranial nerve 6 as it goes through the prepontine cistern into the Dorales canal. Here you see it in the sagittal plane, the very steep course. And then subsequently, this will be the only nerve that is in the cavernous sinus itself, either inferior or lateral to the internal carotid artery. So what kind of pathology can we expect? Infarctions are one of the most common. Sometimes you will have to window it appropriately to be able to see those. Remember, again, facial nerve will be involved in this location as well, so that's an important hint. Here we have a similar appearance on the T2 weighted images where we have edema. However, on the T1, we have just settled enhancement, and this patient had also supratentorial lesions, and this was related to demyelination from multiple sclerosis with a small active plaque. This one was an interesting patient because he came after trauma, complaining of diplopia, and we saw this epidural hematoma along the back of the clivus. The patient became completely asymptomatic a few weeks later because of the resolution of the hematoma itself. Contrast this to this patient where we again have a soft tissue lesion posterior to the clivus, but in this particular patient it's enhancing, and it was proven to be a retroclival meningioma. And here we have a petrous apex lesion that is very destructive. You are losing the cortex along the superior aspect of the petrous apex. That would be per se a non-specific finding, and your differential diagnosis would be quite long. However, if you see it with abscess formation and marked inflammatory changes around it, and the patient presents with a Grad-Inigo triad, then you are thinking of petrous apicitis. However, if the patient does not have any abscess formation, just space-occupying lesion in the petrous apex, think about multiple myeloma or metastatic disease, as in this patient with lung cancer. And here we have a lesion that looks T2 bright. It's not a cyst because it causes marked enhancement. Notice that this is inferior to the intracarotid artery, so within the cavernous sinus, this was a nice schwannoma involving cranial nerve 6. And last but not least, look at the carotid artery itself. Here's a big aneurysm, and you can actually on this CT examination even see what cranial nerve 6 is, and you can imagine that this large aneurysm is causing substantial mass effect upon the cranial nerve 6 on the right side. As mentioned before, you can have cranial nerve 3, 4, and 6 involved at the same time, and this will be classically at the cavernous segment or in the orbital apex. And here are two patients that are very similar in appearance because we have bilateral cavernous sinus involvement. What is here the moneymaker is look around or pull other studies. In this patient, you have enlargement and enhancement of the parotid glands, making this a diagnosis of sarcoidosis, while in this patient, you have enlarged suboccipital lymph nodes, making it the diagnosis of lymphoma. And last but not least, look at the orbital apex fat pad. This is your normal appearance, this is your abnormal appearance, where you have an infiltrating lesion extending into the anterior aspect of the cavernous sinus, enhancing this was a metastasis from lung cancer. So what are the key points for cranial nerves 3, 4, and 6? Always think about it as a single versus multiple cranial nerves involved, because that will guide your view where you need to look. Sometimes you have to re-window your images to be able to see small infarctions in particular. Do I have additional neurologic symptoms? Do I have additional studies that will help me potentially tie the differential diagnosis together? And here, in generating your differential diagnosis, your lesion acuity will be a moneymaker as well. Is it acute versus chronic in nature? Chronicity, you can look also at denervation of the extraocular muscles, how they are distributed, where is the lesion located itself, what are the enhancement patterns, and here again, do I have additional findings? All these will make the puzzle complete, and you will be able to generate a reasonable differential diagnosis. So in summary, for my cranial nerve, CT might be sufficient in the acute setting, in particular when you're dealing with trauma. However, the majority of the time, we will need to have dedicated thin section MRI images, and I like to use volumetric T2 weighted acquisition to demonstrate those nerves in the cisternal segments to its best advantage. I always include the FLAIR and diffusion weighted images so that they can help me generate better differential diagnostic consideration, and I don't have to bring the patient back to potentially look if they have white matter lesions in the setting of multiple sclerosis. And don't forget to include MRA or CTA images when you're dealing with patients with diplopia.
Okay, so for the next 20 minutes, we'll be discussing the trigeminal nerve. The trigeminal nerve has sensory and motor nuclei. The sensory nuclei are 3 in number. The large chief sensory nucleus is located along the anterior lateral aspect of the fourth ventricle, and it's responsible for tactile sensation. There's a superior extension of this nucleus, the mesencephalic nucleus, which extends into the midbrain, is responsible for proprioception, and the inferior extension of the nucleus that goes down into the nucleus of the spinal tract is responsible for pain and temperature sensation. The smaller motor nucleus is located anterior and medial to the sensory nucleus, and this provides the fibers that are going to go on to innervate the muscles of mastication. So the trigeminal nerve is the largest of the cranial nerves and is readily identified on cross-sectional imaging. The sensory component, the larger component, is usually what we're seeing. The smaller component is the motor component is exiting at this level as well. On the midlateral anterior aspect of the pons, it then travels anteriorly and superiorly in the prepontine cistern, and when it reaches the point right here, at the level of the apex of the petrous apex. It pierces the dura in what we call the porus trigeminus, and that's located at approximately this level as we see here on the T2 weighted sequence. So again, it's going to pierce the dura, and then the nerve comes down into Meckel's cave and is surrounded by CSF before it gives off the three divisions. So on the coronal T2 weighted sequence, you can see the region of Meckel's cave nicely with multiple nerves crossing through the Meckel's cave, and on the post-contrast study, you see the ganglion, and then surrounding it, the perineurovascular plexus, so it enhances, so you have this peripheral enhancement around the ganglion itself. After the nerves exit the ganglion, you have the divisions that are forming. You'll have V1, which is the ophthalmic nerve. It travels in the lateral wall of the cavernous sinus and exits the skull through the superior orbital fissure. The V2, the maxillary division, also travels in the lateral wall of the cavernous sinus and exits the skull and the foramen rotundum, scoots across the top of the pterygopalatine fossa, travels in the inferior aspect of the orbit, and then exits at the foramen, the infraorbital foramen just on the anterior aspect of the cheek. The mandibular nerve goes down inferiorly, doesn't cross in the cavernous sinus, exits in the foramen ovale and goes into the masticator space. And there's one important branch that you should be familiar with. That's this branch here, the auriculotemporal nerve here, because it has a communication with the seventh cranial nerve. So when you're looking at perineural tumor spread, this is one of the points where you have a communication between 5 and 7 at that level. Looking at the sensory distribution of the three divisions, 1, 2, and 3, you can see that it provides sensory innervation for the entire face. And keep in mind that V3 is the only one that has a motor component, providing the nerves that go on to innervate the muscles of mastication, as well as some of these other muscles that we have listed here, the tensor tympani, tensor veli palatini, and the mylohyoid and anterior belly of the digastric. As far as the clinical findings are concerned, the patients can have neuralgia, which people call tic de la Rue, and this is the hallmark of this is pain, sudden, intense, sharp, burning, stabbing, or electric type pain that lasts for a few seconds to less than 2 minutes. Or they can have neuropathy, which implies that there's impairment of the nerve function, and this manifests in the form of trismus, muscle weakness, and sensory deficits as we have listed here. So whenever you're looking at the nerve, it's always nice to look at it and divide it into the various segments. This is going to help you to remember how to image the nerve as well as some of the pathologies that occur in this region. So we're going to divide it into the segments, the brainstem, the cisternal segment, Meckel's cave and cavernous sinus, and the peripheral nerves. And this is just a list of the types of pathology that we see in the brainstem region. We have neoplasms, either primary or metastatic, vascular pathology with infarcts or cavernous angiomas, inflammatory disease, and then also autoimmune disease, and we put in that category multiple sclerosis. So when we're imaging this part, the brainstem and upper spine, you really want to use T1 fat-sat images and thin fast-spin echo images to evaluate the region of the nuclei. So multiple sclerosis is the most common entity that leading to the development of trigeminal neuralgia, and it presents presenting symptom in only about 4% of cases. And depending on the phase of plaque formation is going to determine what the imaging is going to look like. So on in the acute and tumefactive phase, the T1 images, it's going to have low to intermediate signal, long TR sequences, high signal, and it will enhance post-contrast. In the chronic phase, on T1, it's hypointense, long TR sequences, hyperintense, and we'll see no evidence of enhancement. So here in this patient, it's a 35-year-old patient with a past medical history of multiple sclerosis who presents with dull, constant pain and decreased sensation on the right side of the face, and we see T2 hyperintense signal on the right middle cerebellar peduncle and right pons at the origin of the trigeminal nerve. And then following the administration of intravenous contrast, we see a ring enhancement in the region of the right peduncle and subtle enhancement in the pons on the opposites on the right side, indicating that there is active demyelinization. The sequel of prior demyelinization is seen on the left, where we have no evidence of enhancement in the region where we have the lesions. This is a 10-year-old boy who has ADEM, and in this particular patient, this is the patient presented with brainstem symptoms. This is an acute inflammation of the brain, the cord, and occasionally the optic nerve. It's supposedly autoimmune mediated, and it's a response to the myelin in the brain and cord, and has similar findings, somewhat similar to that of MS. The etiology is unclear, but in most cases, in about 50% of cases, the symptoms appear after a viral or bacterial illness, usually 7 to 14 days after an infection and up to 3 months after vaccination. So here in the patient here, we can see that there's this increased signal here on the FLAIR images, anterolaterally and posteriorly in the region of the pons, and I put the sagittal image there also so you could see nicely where the lesion is located, and this would explain why the patient could have possible involvement of the 5th cranial nerve. Metastatic disease is always a possibility when we're looking at disease that involves the nerves. In this particular patient, we see that there's edema of the right middle cerebellar peduncle, and also along the trigeminal nerve is image shown here in blue. And then we have mild edema on the right side of the pons and a corresponding ring-enhancing lesion on the right side of the pons, explaining why this patient presented with 5th nerve findings. Wallenberg syndrome is when we have infarcts in the lateral medullary plate, and this is a 65-year-old patient, and I'm just going to call your attention to these findings, that she had dull left facial pain and decreased sensation on that side of the face, and that's because they have involvement of the nucleus and the spinal tract of 5. So when we look here, we see that there is increased T2 signal in the medulla and the posterior cerebellum, consistent with an infarct with restricted diffusion in the same areas as well. On the CTA, there is some diffuse narrowing of the left pica, and we see the normal size pica on the opposite side. The illustration is showing you the location of where the infarct is, so the patient will have multiple nerve findings, but I'm just showing you this particularly just to point out that the 5th nerve may be involved as well. Moving along to the cisternal segment, we have a large number of lesions that we can see in this region: neoplasms, metastatic disease, perineural tumor spread, hematogenous spread, leptomeningeal spread of tumor, as well as inflammatory disease, neurovascular compression, aneurysms, AVMs, and inflammation, particularly in things such as sarcoid, herpes, and Lyme's disease. So when you're looking at the cisternal segment, the cavernous sinus, and Meckel's cave, people often like to use 2D and 3D T2 gradient echo images to evaluate this region. So schwannomas are the most common intrinsic neoplasms of the 5th cranial nerve, and is second in frequency only to those that are found in the region of the 7th cranial nerve. And these patients can present with pain, paresthesias, and numbness. They may have symptoms related to involvement of the adjacent nerves and muscle atrophy if there is a motor nerve involvement. So this is a small lesion that's located in the prepontine cistern. We can see that it's hypointense to brain on the T1 weighted sequences, isointense on the heavily T2 weighted sequences, and that it enhances following the administration of intravenous contrast. So that's a fairly characteristic appearance, and there's the normal nerve on the opposite side. Again, metastatic disease can also involve this area as well. We see that there is an enhancing cisternal segment here on the right, and that this lesion is coursing through the pores trigeminus, and there's an enhancing lesion on the left side of the pon near the root entry zone and with surrounding edema, thus explaining why this patient has bilateral 5th nerve findings. A 32-year-old patient with trigeminal neuralgia. On the T1 weighted sequence, it looks as if the right side of the cistern is larger than the left. That's because there's a lesion there. On the T2 weighted sequence, it has a heterogeneous areas of hypointensity coursing to it, so it's not totally the same density as CSF, which is what we usually expect to see in patients with epidermoids, but there is restricted diffusion. So this was sort of an atypical epidermoid in this patient, and it shows you here that it's causing some compression of the nerve as it's coursing through that prepontine cistern. This was a 70-year-old male who had a 2-week history of bilateral lower extremity and a 2-day history of right greater than left upper extremity weakness. So the working diagnosis in this patient was Guillain-Barré syndrome, and here we see that there's diffuse leptomeningeal enhancement as well as enhancement of the nerve roots in the region of the cauda equina. The patient, however, then developed some 5th nerve findings, so they did a scan looking for evidence of disease in that region, and here we see thickening of the region of the 5th cranial nerve. You can see it on the axial and on the sagittal image, nicely demonstrating how it makes that turn when it's going down towards the ganglion. And here we can see it on the coronal image as well. The trigeminal neuralgia is the most frequent facial neuralgia. We mentioned the type of pain that they usually have. It's usually involving V2 and V3. Only about 5% of the time will you see it involving V1. It's usually triggered by sensory stimuli in certain areas and usually close to the midline. The clinical examination is usually normal. In about 15 to 25% of patients, they'll have slight sensory impairment, and this is usually due to a tortuous superior cerebellar artery. So again, you can use the same imaging sequences that we use to look at the cisterns, and then you can add to that the vascular portion of the study using time of flight images or looking at contrast-enhanced MRAs to evaluate them. So here's a case of a 35-year-old patient with multiple attacks of shooting pain in the left cheek and upper lip. And in this patient, you can see where there is a neurovascular compression along the superior medial aspect of the nerve, likely affecting the fibers of V2 and 3. There's slight atrophy of the nerve as well, and we can see that this is our superior cerebellar artery in this patient. The reason that this area is most sensitive is because this is the transition zone. It's the junction between the central and peripheral myelin, and it's the most vulnerable part of the nerve when it's for compression injuries. The reason why V2 and V3 are commonly involved is because the vessel that's compressing is coming down from superior medial, and this is the orientation of the nerve fibers in the nerve at this level. So V3 is superior and V2 has components medially. That's why you see it more often involving V2 and V3 rather than V1. Moving along now to the cavernous and Meckel's cave region. Again, the same sorts of pathology that we normally will see in some of these regions. But again, I just want you to remember that the central skull-based lesions such as chordomas, chondrosarcomas, and plasmacytomas may grow up into this region as well and mimic some of these lesions. This is the characteristic lesion that everybody talks about. It looks like a dumbbell-shaped lesion in the patient. Here we see a portion that's in the prepontine cistern, the other portion involving the Meckel's cave. It enhances following the administration of intravenous contrast, and the little waste that we see on the lesion here is caused by the lesion when it's coursing through the pores trigeminus. That's why we have that appearance. This lesion looks somewhat similar when you're looking at it. It has the same components, a component in the prepontine cistern and Meckel's cave. When we look at the post-contrast image, it does, however, look as if it has a broad base on the dura. We do see dural tails in this region. This was a meningioma. Looking at the coronal image, you can see the fifth nerve on the left side and see how the lesion is extending superiorly. So it's easy to see why this patient could have fifth nerve symptoms as well. Lymphomas and leukemias can reach the cavernous sinus by direct extension or hematogenous spread, and usually they are T2 hypointense, but can cause diffuse enlargement and enhancement of the cavernous sinus, and usually without arterial narrowing. So looking at the patient here, we see that there is a lesion in the cavernous region of the cavernous sinus on the left here. It doesn't change significantly in signal intensity on T2, but it does have mild enhancement, and you'll see that there's no significant change in the size of the caliber of the internal carotid artery. This is a patient with Toulouse-Hunt syndrome. This is a painful ophthalmoplegia that occurs secondary to nonspecific inflammation in the cavernous sinus or the superior orbital fissure. This patient in 2005 was successfully treated for idiopathic orbital inflammatory disease and now presents with headache, right eye pain, and decreased ocular motion. So we see here that there is enhancement in the region of the superior orbital fissure and apex, and marked enhancement in the region of the cavernous sinus, and that there is marked narrowing of the internal carotid artery on this side in this patient with Toulouse-Hunt syndrome. Petrous apicitis is secondary to retrograde thrombophlebitis, and it occurs only in patients with pneumatized petrous apex. And so here we see on the CT scan that there is opacification of the petrous apex air cells. There's some loss of the septations, just as we would expect to see in somebody with a coalescent mastoiditis. Increased signal is seen in the region of the air cells on MR, and then below the skull base, there's marked enhancement that we see here in this patient. So if you were doing diffusion studies, there would be restricted diffusion. The clinical findings that we see in this triad, otomastoiditis is one, abducens nerve palsy, which is diplopia. That's because the sixth nerve becomes compressed as it courses over the petrous apex under Gruber's ligament. And then the trigeminal pain and paresthesias in the distribution of V1 and V2, where the nerves are found in the region of Meckel's cave. And it really is uncommon to see all the full triad in most patients. Now let's look at the peripheral nerves. When we look at the peripheral nerves, you can certainly have schwannomas. They're actually rare, and when we do see them, they're more common to involve V1. Neurofibromas, when we see them, they usually involve V1 and V2, and it's not common for them to extend into the region of Meckel's cave. You can have findings because of compression of the nerve or inflammation along the region of the nerve. Trauma, particularly orbital and facial bone trauma, can affect the nerves in this region, but by and large, what we see when we're looking at disease that's involving the peripheral nerves is perineural tumor spread. And so with perineural tumor spread, it's important with imaging to obtain T1 pre-contrast as well as T1 FAT-SAT post-contrast images, and you can use multiplanar gradient echo T1 sequences for the anatomy to visualize the nerve along its entire course. And remember that with perineural tumor spread, it's important to visualize the entire nerve because you can have skip lesions. The most common nerves involved with perineural tumor spread: the fifth cranial nerve, usually V2 and 3, because they have the largest distribution of nerves in the facial region, and the facial nerve. And then another thing for you to remember, and why it really is important for you to be able to recognize the findings of perineural tumor spread, is because 40% of these patients are asymptomatic. So the radiologist may be the first person to pick up these findings on cross-sectional imaging. So let's just look at a couple of cases. This is a patient with a carcinoma of the lower eyelid here that we can see nicely on the images, that there's widening of the infraorbital canal in this patient. We see evidence of tumor in the inferior orbital fissure. You'll see that there's a difference in the density here of the fat compared to the opposite side, and the same thing is true in the region of the pterygopalatine fossa in this patient. So this is where the tumor has traveled from here back to approximately this point based on our imaging study. Here's another patient with a history of recurrent squamous cell carcinoma of the lower lip on the right side. And you can see that when you look at the lesion here, it looks as if it's eroding the bone here in the region where the mental foramen is located. So it's not unlikely then that what we see here is that the fat in the inferior alveolar canal is infiltrated on that side compared to the normal fat on the opposite side. You can see the nerve coming down here between the medial and lateral pterygoid, going over towards the inferior alveolar canal. And then here we see nicely that the lesion is actually tracking along the auriculotemporal nerve in the region of the stylomandibular tunnel. So it's going over to involve the seventh cranial nerve. Just to talk about that auriculotemporal nerve just a little bit, it rises from V3 almost immediately below the level of the foramen ovale and travels through the region of the masticator space as well as the parotid space. It loops around the middle meningeal artery, and then it travels laterally in the stylomandibular tunnel, and that's the area between the posterior aspect of the mandible and the styloid process. This is the stylomandibular tunnel. So this is where you're going to see the auriculotemporal nerve, where the tumor is traveling along that back to the seventh cranial nerve. The other important thing for you to be familiar with is the trigeminal fat pad. This is something that Dr. Curtin always talks about. And if you think in terms of the nasopharynx, that the nasopharynx is actually very close to the parapharyngeal space. So this is the pharyngobasilar fascia. The tensor veli palatini muscle is in the parapharyngeal space. So when you look at this patient that has a carcinoma of the nasopharynx on the right side, you can actually see that tensor veli palatini muscle there. So we can see there's even a fat plane between the tumor and the muscle, telling us that this tumor is confined to the nasopharynx. If the muscle is involved, we know that the parapharyngeal space is involved in this patient, and when we look just lateral to that muscle, we can actually see V3. And that's why it's important, because once it goes into the parapharyngeal space, it can jump onto V3 in these patients. So here's a patient that also we're just going to show you again. I want to draw your attention to this region here of the trigeminal fat pad. In this region where the nerve is, and if you look there closely, you'll see that there is soft tissue density around that nerve, and as we follow it superiorly, you're going to see that it's going all the way up through the region of the foramen ovale, and then it stops at the level of Meckel's cave. And looking on the coronal images as well, you can actually see that tumor growing all the way up to the region of the skull base with some destruction of the skull base as well. So that's why it's always important for you to look closely at that trigeminal fat pad. So just to end with this particular case here, and it's just to point out that you can have denervation atrophy of the muscles of mastication. This is a patient who had recurrent nasopharyngeal carcinoma. So this is what we saw at the time of the initial presentation. The patient had opacification. There was fluid in the eustachian tube, and we know to find the eustachian tube, it's located just lateral to the intrapetrous portion of the carotid. There's fluid in the middle ear and opacification of the mastoid air cells. So this patient has serous otitis. Serous otitis in an adult patient, you should always worry about nasopharyngeal carcinoma until proven otherwise. And the patient also has enlargement of the foramen ovale on that side. When we look at the middle image here, we can actually see that trigeminal fat pad is abnormal. Look at the normal fat pad on the opposite side. And when we look on this image, we can see that there is evidence of denervation atrophy in the muscles of mastication in this patient.
Okay, so I was tasked with talking about neuroimaging of the facial nerve and the vestibulocochlear nerve, the 7th and 8th nerves. In terms of why should we discuss them together, well, we're trying to go 1 through 12, obviously. These nerves do have no real functional overlap, but they do share some space. They share some anatomic space, mainly from the brainstem out toward the inner ear. And if we look at that shared space a little bit here, we see we're at the brain stem here, we can see the pons, we can see the medulla, and you'll see the 6th nerve here, and obviously the 7th and 8th nerve are going to rise from the pontomedullary junction in the lateral aspect of the CPA. We can look at this too in the axial graphic here, and it just shows the 7th and 8th nerves extending through the CPA and into the IC, and often they're grouped together with imaging. We don't separate them out, and sometimes we just simply refer to them as the 7th and 8th nerve complex. We can do state-of-the-art imaging, high-resolution T2 weighted imaging now with 3T. You can pick a sequence based on your vendor. I like 3D Drive. And we can actually select out the individual nerves now, like the 7th and 8th nerves, leaving the cerebellopontine angle. And if we can scroll up and down and actually visualize the different nerves, including the cochlear nerve and the inferior vestibular nerve, like you see here. It's sort of a classic teaching now to kind of do this sagittal approach here, where we can see all 4 nerves in profile here, and you see that this is anterior to your left, so this is facial nerve, this is cochlear nerve, and then here's a graphic just showing those same nerves that we can see with high-resolution imaging nowadays. So we're going to look at the facial nerve first, and just remember that there are diverse functions. It animates the face, obviously, but there are also other things that it does, parasympathetics to the lacrimal glands, sensation to the soft palate, sensation to the external auditory canal, and taste to the anterior thirds of the tongue. Now, this is going to be a relatively intricate anatomic network. It's going to extend really from the cortical innervation through the brainstem, and then there are going to be some distinct nerve fibers that we're going to mention that play a specific role. And then, of course, we're just going to try to track the facial nerve through the temporal bone and through the parotid. So what's our role when it comes to the facial nerve? Well, we're most often asked to identify a cause of facial paralysis in a patient. In a university setting, I spend a lot of my time trying to figure out if there's a malignancy that affects the facial nerve, specifically perineural tumor spread, and also we're asked to identify causes of hemifacial spasm, mostly neurovascular compression. So at the clinical side of things, the first question is a clinical one. Does the patient have a central facial paralysis? Is it something above the brainstem, or is it a peripheral facial nerve paralysis? Does it involve the distal nerve, or is it the brainstem nucleus? Now these can be separated out clinically in the ER, and they're usually pretty good at that. On your right, you'll see a patient with peripheral facial nerve paralysis. The entire right side of the face is involved. The lower face is involved, and the forehead is involved, and the eyebrows involved. On the left side, you see the central facial nerve paralysis depicted, where we have the lower faces involved, but there is some maintenance of function in the upper face, particularly the forehead. And that's what they do at the bedside. And that's pretty important because if you're dealing with the central facial nerve paralysis, almost all of those would probably get advanced imaging. If you're dealing with a peripheral facial nerve paralysis, this is going to be our Bell's palsy bucket here. Most of those don't need to be imaged. So it's important first distinction. So let's look at central facial palsy and cortical innervation. Obviously, we're looking at the frontal lobe here, the primary motor cortex, and the upper motor neurons for facial innervation are out here laterally, just above the insula. We call this the frontal operculum, okay? So that's where the nerves are going to begin. Here is the motor homunculus here, again, foot, arm, hand, and here's the face way out laterally involving the frontal operculum, okay? Now notice we can draw some fibers that descend down from the cortex, and I'm going to draw 2 red fibers from the upper face and a single yellow fiber from the lower face, and we can track these cortical bulbar tracts down into the brainstem where we find our facial motor nuclei. And notice the red fibers went both ipsilateral and contralateral, and the yellow fibers only went contralateral. So there's bilateral innervation of the upper face and only contralateral innervation to the lower face. So that's important in making this distinction clinically. Any lesion above the motor nucleus will cause a contralateral central facial nerve paralysis. Okay, because there's still going to be innervation from the unaffected side. So how does this occur? Well, we see this all the time, right? This is an MCA infarction. It's subtle. There's loss of gray-white differentiation, but the entire motor cortex is taken out. So it's not just a facial palsy. Multiple other motor units are involved, and also other eloquent cortex. This is a little bit smaller. Again, right frontal operculum is involved. This one's subacute. It looks a little bit mass-like, but this is a subacute infarction, a little bit smaller volume, and there are some additional neurologic deficits. Here's one. Patient's lost the MCA, but there's just a tiny little isolated infarct out here in the region of the facial primary motor neurons. So obviously anywhere between the cortex and the brainstem can be affected, and it's not just strokes, it would be brain tumors and multiple sclerosis, other things that we've seen already in these first 2 talks. But here's a lacunar infarct, just reminds us that those facial fibers can be interrupted and give us a contralateral central palsy. Now, when we get to the brainstem, it switches from a central process to what we call an ipsilateral or peripheral facial nerve palsy. So here's the motor nucleus. If you take out the motor nucleus, everything on that side of the face is going to be involved, the entire face, and it's going to look very much like a Bell's palsy. Here's just an example of that. This is a patient who presented to the ER, and it looked like a peripheral facial palsy. He was diagnosed with Bell's palsy, sent home, and the next day he had some new neurologic symptoms, so he came back and we got some imaging. This is a DWI image. It looks pretty unremarkable in the B1000s, but the B2000s does elucidate the fact that there's an infarct in the left facial nerve nucleus. So the teaching points here, of course, just in everyday practice, a small percentage of brainstem strokes will be missed early on the DWI images. B2000s actually increase your sensitivity for that, so we do this on everybody, and we see an extra couple of strokes a year. I'm not sure it's entirely worth it, but we're at a university, so we have to do things like that. And then finally, just remember that all peripheral facial nerve palsies are not Bell's palsies, okay? So think about that. Let's talk about the brainstem relationships. We've already seen this a little bit, and let's remember, here's the 4th ventricle. There's a little bump here we call the facial colliculus, and then there's a little nucleus under that, the 6th nerve nucleus that Ilona has shown you already. More medially within the brainstem is the cranial nerve 7 motor nucleus. Now the motor fibers are going to come out, extend posteriorly, wrap around the 6th nerve, and then extend anterolaterally to the pontomedullary junction. The importance of that is if you have a lesion here, you can actually produce a syndrome called the facial colliculus syndrome, where you've got both ipsilateral cranial nerve 6 and ipsilateral cranial nerve 7 palsies. So we saw that with Ilona's case, where she showed you a small stroke. Here's another one. This patient presented with 6th and 7th nerve palsies. Obviously, she's got some chronic disease, supratentorial and as well as in the brainstem. And of course, we're going to use our diffusion restriction to show us the lesion, and it's right where it should be in the facial colliculus. Here's a patient I saw. I looked at the scan. I thought it was normal, and then I looked at the history and said, well, 24-year-old. 1 week earlier, she had a left 6th nerve palsy. Now she has a left 7th nerve palsy. And now you kind of think, well, wait a minute. She probably couldn't make this up. So I look in the facial colliculus, and there's a 2-millimeter lesion right where it should be on the left here. And here's the enhanced versions of this. And this turned out to be a lupus vasculitis involving the facial colliculus. Some other brainstem nuclei that we want to mention here. It's not just a motor nerve, there are other components. This is the superior salivary nucleus in the brainstem. It provides our parasympathetic, allows us to cry. You know, if you're watching This Is Us every Tuesday night like I do, you just cry like this is it right here. This is the This Is Us nucleus right here. And then there is the tractus solitarius, which is for sensory. These two fuse together in what we call the nervus intermedius. So it's an important nerve. Most of the time we just sort of visualize it mentally as just blending in with the rest of the motor fibers. But it is depicted in a lot of illustrations as an intermediate nerve between the 7th and 8th nerves. And you will see it at dissection. I don't know if any of you are operating this week, but here's the ICA loop. Here's the motor component of the facial nerve. Here's the nervus intermedius separated by the ICA loop in this dissection here. And yes, we can even image it here. This is from Burmeister et al. In 2011, AJNR, where they've actually depicted that nervus intermedius as a tiny nerve in between the 7th and 8th nerves. So it can be imaged, and it does produce syndromes. Now, if we step beyond the brainstem and look at the peripheral nerve a little more closely here, we can start to elucidate the number of segments or landmarks of the facial nerve. So first, of course, CPA and IAC, and before we go too far, I just want to mention hemifacial spasm and its relationship to the proximal facial nerve. So we've seen some neurovascular compression already, but hemifacial spasm is characterized by unilateral spasm of the face. It can be fairly debilitating, and it's most often caused by vascular compression, and the proximal nerve is where the nerve is most vulnerable. We've done a lot of histologic evaluations now. You've seen a lot of this in the literature. This is from Journal of Neurosurgery, 2003. And if we look at the pons and the medulla, here's the nerve escaping from the root exit zone. Then it remains attached to the pons. Then it separates, and there's a transitional zone between the central myelinated component and the peripheral myelinated component, and it's really these proximal 3 or 4 millimeters that are most vulnerable to vascular compression, so that's where we want to look. Here's an axial and coronal T2 weighted images showing this right vertebral artery, very tortuous, comes all the way over to the left, does a 180-degree turn and impacts that root exit zone right at the pontomedullary junction. It's a classic finding, so this is what I'm looking for. I'm looking for a named artery, I'm looking at the pontomedullary junction, I'm looking for deformity of that. That's going to help me. Here's another one, much smaller vessel, but it came from below, from the vertebral artery. This is a pica vessel right here, and again, it's impacting that root exit zone, it's deforming the pontomedullary junction, a classic case of right-sided hemifacial spasm. I found this case on the internet. It's a published case, but the vessel's doing the exact same thing, 180-degree turn, impacting the root exit zone of cranial nerve 7, and this is what happens when they try to fix it. They put this Teflon sponge in between the nerve and in between the artery to separate it chronically, and it's a fairly successful surgery. Now, if we think about the CPA and the IAC, obviously it sort of lends itself to discussing this differential for CPA and IAC lesions. And obviously we know that the most common thing we're going to see here is a vestibular schwannoma, but there are other less common things such as meningioma, leptomeningeal metastases, vascular lesions like aneurysms and AVMs. And if we try to think about these in terms of how do these relate to the facial nerve, well, it's very unusual for vestibular schwannomas to produce facial paralysis. It's probably less than 2 or 3%. The facial nerve is very resistant to compression by these vestibular schwannomas. The schwannomas will just kind of push them out of the way or obscure them so that we can't even really identify it. Same is true for meningiomas in the CPA. They rarely produce a facial paralysis, rarely produce hemifacial spasm. They most often act like vestibular schwannomas. They produce hearing loss and headache, things like that. Here's a lesion, a 52-year-old with headache, loss of balance, and right facial nerve palsy. And this patient has a complex lesion here. It's solid, it's cystic, it's enhancing, and you might first think, well, maybe this is a vestibular schwannoma, but there's right-sided facial nerve palsy, which makes us want to look a little bit further, and we're going to look further out along the course of the geniculate ganglion and see that there's another nodular component. This is a classic dumbbell-shaped mass, and this is indeed a facial nerve schwannoma. These are relatively rare, but there is a predilection for the CPA, the IC, and the geniculate ganglion, and it turns out most of these do present with facial nerve palsy. Here's another case. Enhanced view looks like a vestibular schwannoma, but again, we have to look up over the top, look at the geniculate ganglion, and on CT, you might see widening of the labyrinthine segment of the bony canal. As we continue on with our anatomy lesson here, again, here's a facial nerve, here's a labyrinthine segment, geniculate ganglion, there's a greater superficial petrosal nerve that's going to deliver the parasympathetics to the central skull base in the face, and then there's the tympanic segment that you can see here and the posterior genu. CT is nice because we see those bony canals that carry the nerve in a similar fashion. Here's the mastoid segment of the facial nerve. You can often follow the mastoid segment down through the mastoid air cells, unless there's pathology there that makes it a little bit more difficult. Here's just an oblique sagittal image where we can see the tympanic segment and the mastoid segment all in one plane. And I'll just point out that you want to pay attention to the fat pad, just like with the trigeminal nerve, there's stylomastoid fat as well. And if that's obliterated, you might want to consider that there's tumor involved in this area. And remember, there's a stylomastoid artery and vein that often gives you some enhancement in this area, so everything that enhances in the mastoid segment is not necessarily pathologic. Now, as the facial nerve exits stylomastoid foramen, it passes through the parotid gland and divides up into multiple peripheral branches: temporal, zygomatic, buccal, mandibular, and cervical, the famous to Zanzibar by motorcar mnemonic that some of you might remember. So as we turn our attention now to cranial nerve paralysis, Bell's palsy is going to dominate the discussion. It's the most common, and there are others, trauma and Ramsey-Hunt, etc. We have to understand what's normal enhancement on MRI. The IAC and CPA, there should not be any enhancement. Geniculate ganglion is quite variable, as well as the tympanic and mastoid segments are variable. But notice as we go down, the mastoid segment seems to enhance, probably because of that neurovascular bundle at that location. And also realize it can be somewhat asymmetric, as you see here in this case. Here's a patient with Bell's palsy. There's a little bit of enhancement here. It's not dramatic. It doesn't jump off the page unless we compare it to the other side, and this asymmetry is quite characteristic. And there's also asymmetric enhancement of the mastoid segment. I'm not sure I have a timer up here, so okay, no timer. Okay, great. Be here forever. Okay, so again, asymmetric enhancement of the mastoid segment. This one's a little more problematic for me, but this is another case of Bell's palsy. It just reminds us that it can be robust enhancement. This is slightly more nodular, and this would make me think more like a perineural tumor spread, but it just underscores the fact that the appearance is nonspecific, and it's not necessarily diagnostic of Bell's palsy. You want to fit all the clinical factors in there, and you hope it resolves, and if it hasn't improved in 3 months, you want to be suspicious that we're dealing with something else. When should we image Bell's palsy? Because it's not routinely recommended. Well, obviously, if we think it's a central facial paralysis, if there are other focal neurologic deficits, if the onset is atypical, instead of a few hours, it's days to weeks, you got to think about perineural tumor spread. If it's recurrent or bilateral, and if there's no improvement after 3 months, and in my world, especially if you have a history of head and neck cancer, you have a new facial nerve palsy in that patient, he deserves advanced imaging with MRI pre and post contrast. Ramsey-Hunt syndrome is another inflammatory infectious process, reactivation of varicella zoster. When I see these, and I've only seen 3 or 4, they tend to be a little bit more nodule, a little bit more robust enhancement within the IAC compared to a Bell's palsy. And if you're lucky, you might see the area of herpetic rash in the ear that's enhancing, as we do in this case. Now, malignant neoplasm of the facial nerve, there's a number of ways in which the facial nerve can be involved by malignancy. Obviously, one of the ways we think of first probably is a giant primary parotid tumor that's invading the nerve. That's one way, but there are also other ways. This is an example of leptomeningeal carcinomatosis from breast cancer. This patient had both 7th and 8th nerve symptoms, and you could see there's nodular enhancement within the IAC, but also within Meckel's cave as well. And these tumor deposits just sort of track around and, for whatever reason, preferentially involve the IACs and Meckel's cave, and sometimes this is probably scattered through the CSF, but sometimes I think it's hematogenous, and sometimes we just don't know. But that's breast cancer, a very typical appearance. Here's another example, 57-year-old with melanoma. This patient has nodular enhancement. The patient presented with ataxia, vertigo, bilateral hearing loss, and left facial weakness, so 7th and 8th nerve symptoms, a typical case of leptomeningeal carcinomatosis. And we might want to comment that if you see this on your board exams or your CAQs, this is probably NF2 until proven otherwise, but in the world of cancer imaging, you at least want to think about it. Here's a case of metastatic breast cancer to the right temporal bone. This patient had a single solitary metastasis in the entire skull base and calvarium, and here it is. You can see the mastoid segment of the facial nerve here, and just below that, there's a lytic lesion that's destroying the sigmoid plate here, as well as the jugular foramen, single lesion. One of the things I like to talk about is perineural tumor spread. You've seen a couple of cases already. This is a lesion, obviously in the deep medial aspect of the parotid gland that we can see on CT. Classically, these things extend in a retrograde fashion, burrow up the mastoid segment across the genu and into the internal auditory canal. Here's the coronal MRI in that patient showing this thick enhancement of the mastoid segment. And if we look over into the IC, there's abnormal enhancement. Here are the axial views for that, showing nodular enhancement. Again, this doesn't look terribly different from our Bell's palsy that we looked at earlier, but there's nodular enhancement in the IC, and this is a good example of perineural tumor spread. So we turn our attention now to the eighth nerve, the eighth cranial nerve, cochlear and vestibular components. One is for hearing, vestibular components are for balance. These nerves are essentially bipolar neurons that have cell bodies. Nerves go out to hair cells, they innervate particular hair cell organs in the inner ear, and then they carry information back to the brainstem. So let's look at the cochlear nerve. Here's our spiral ganglia where these cell bodies are located, embedded within the modiolus here, and they innervate the organ of Corti, which is a hair cell organelle within the scala media. So sound comes in, transmits energy to the fluid, and then that fluid energy and movement is transferred to the hair cells, and then that's transferred into a nerve impulse to go back to the brainstem. And this is what interprets hearing and allows us to hear. So in terms of neuroradiology, obviously we're asked to look for reasons for deafness, we're asked to look for reasons for sensorineural hearing loss, and we know those pathologies are diverse. They can be congenital, they can be acquired, they can involve the cochlea, the bony labyrinth, the membranous labyrinth, and they can involve the nerve itself. And day to day, of course, most of the time we're looking for a vestibular schwannoma that's compressing that IAC or cisternal portion of the nerve itself. But I want to mention this one just because it's listed as one of your questions for the SAMS course. Let's look at the cochlear nerve canal and cochlear nerve deficiency. So the nerve has to go into the modiolus. It has to transmit nerve fibers. So there's an opening here we call the cochlear nerve canal. And you can see a normal one here, and it's in measurable quantity, okay? And it's usually about 2 millimeters. If that is really small or absent, you have to consider that there's no nerve or not enough nerve to perform its function properly. So this is just a spectrum, normal here. Here we've got a little bit of a bony narrowing of that cochlear nerve canal, and here we have a complete bony bar. So the implication is that if there's no opening, then there's really no nerve or not sufficient nerve to allow the patient to hear. So here's an example of a 5-year-old with congenital deafness. This is a little bit of an older study, so I apologize that it sort of jumps around. But what we're looking for is an opening into the modiolus, and this is just a complete bar as we go across here. Now, compare that to the normal side where we have a definitive opening. Now, we can do some 3D reformations on the normal side here, and what you might see if we're looking down the IAC, here's the cochlea, and here's that connection, okay? When I see this, I think it's sort of like a mushroom and a stalk there, but there's a very healthy stalk, if you will, cochlear nerve canal. And if we look at, and we can almost envision the cochlear nerve extending into the modiolus there. Here's that patient's right side that's abnormal here, and again, we've got the mushroom top, but there's no junction here, okay? It's a deficient opening. There's a bony bar across there. So either the nerve was damaged soon after it was formed, or it never fully formed in this case of congenital cochlear nerve deficiency. Again, normal and abnormal. We can also use MRI. We can occasionally see absence of the nerve. Here we are, the 7-up, and this is Coke 0, I guess. Here's another interesting patient. The patient was a 19-year-old with congenital deafness and had a failed attempt at a cochlear implant on the left side, and now they're considering doing something on the right side. So we get this CT, and I do my little 3D reformations here and go, wait a minute, there's no cochlear nerve opening here. There's no communication between the cochlea, so it's unlikely that the cochlear implant is going to work on this side. But remember, she already had an implant on the left side, so I said, well, what happens if we do a 3D with this one? Look, there's no opening to begin with, so you can see some artifact from the electrode within the cochlea itself, but there's no communication here, so it sort of makes sense that that's why this one failed. There's congenital absence of that cochlear nerve. And finally, we'll end with this, the superior and inferior vestibular nerves. Obviously, the nerve bodies are in scarpus ganglia. We don't see that on imaging, but little dilatations of the nerve just at the distal end of the IAC. These are going to innervate hair cells within the utricle, saccule, and the semicircular canals. And of course, the dominant player in this is vestibular schwannoma. And just remember, they come in a lot of shapes and sizes. Here's one that's about 2 millimeters on a non-enhanced view. Here's one a little bit larger, involving the canal and slightly extending into the CPA. They can be somewhat bizarre. We've already seen a cystic schwannoma of the facial nerve. They can be very cystic. The cyst can be inside the parenchyma of the nerve and can be along the mural margins of the nerve. And then here's a hemorrhagic vestibular schwannoma. And again, if you're taking the boards, remember this one. If you see this case, it's pathognomonic for NF2. So in conclusion, we've kind of looked at the 7th nerve. We've looked at some anatomy. We've looked at some interesting cases. We've looked at Bell's palsy, hemifacial spasm, and examined how malignancy might affect the facial nerve. And we've also looked briefly at the vestibular cochlear nerve. And for the Sam's question, remember cochlear nerve deficiency. And we've also briefly discussed the differential for some CPA IEC lesions. So thank you very much.
All right, here we go. So I've been given the task of dealing with cranial nerves 9 through 12. So let's start off with the glossopharyngeal nerve. This is essentially a mixed nerve. It primarily has sensory innervation to the pharynx and part of the carotid bodies. It's a motor nerve only for one muscle, which is the stylopharyngeus muscle, and it has got important secretory function for the parotid glands. That's all you need to know. The vagus nerve is the longest cranial nerve in the entire body and is also a mixed nerve and provides sensory and motor innervation for both the pharynx as well as the larynx. And it's the primary parasympathetic nerve that supplies many of the organs in the chest and abdomen. The accessory nerve is a primary motor nerve, and there is a spinal contingent and a more controversial cranial contingent, but we'll just focus on the spinal contingent. And this supplies two muscles, which are namely the trapezius and the sternocleidomastoid muscle. And the fourth one is a hypoglossal nerve, and it just supplies all the muscles of the tongue with the exception of the palatoglossus, which is supplied by vagus. So that's something you might need to remember for later. Now, when you dive a little bit deeper into the anatomy, this is a cartoon that depicts the location of various nuclei here. A question that always comes up with my residents is, how am I going to know where the nucleus ambiguous is or where the solitary nucleus is? I tell them, if somebody comes down and asks you, just wave your mouse over this region, you'll be fine. You don't need to know exactly. So one thing you do need to know is where these cranial nerves enter or exit the lower brainstem, which is the medulla. So if you cut the medulla into a hemisection, the anteriormost bump is the pyramid. It contains the motor tracts. The lateral bump is the olivary nucleus. So all you need to know is the anterior one is pyramid, the lateral one is olive, and the cranial nerve 12 exits between the two. So it has got a more anterior exit, and the cranial nerve 9 and 10 are retro-olivary, which means they exit behind the olive. So this is the only thing that you actually need to know amongst the various anatomy that I've just shown you. You also need to know where these cranial nerves exit the skull base and where they are in the neck. So let's look at that. So in the jugular foramen, there are two portions. The lateral portion is the pars vascularis. It contains the vascular structure, which is the jugular bulb, and along with it, the 9th and 10th cranial nerves. The 10th and the 11th cranial nerves. The more medial portion, which is the pars nervosa, contains the 9th cranial nerve and a small venous structure called the inferior petrosal sinus. So in many instances, it is difficult to figure out where exactly each cranial nerve sits, but it doesn't matter because if a pathology involves the jugular foramen, you can be sure most of these nerves are going to be involved in tandem. What you do need to know is, on a high resolution T2 weighted MR, can I identify some of these nerves? And the answer is yes. So as I just mentioned to you, this is the section of the lower brainstem or medulla. The anterior bump is pyramid. The lateral bump is olivary. So something that comes out retro-olivary has to be either the 9th or the 10th cranial nerve. So this is where you will find them. If you find a small structure that comes out between the pyramid and the olive, it is going to be your hypoglossal nerve. The hypoglossal nerve, once it exits the brainstem, it makes its way through a slightly different foramen, which is the hypoglossal canal, also called the occipital condylar canal. Now this is a close cousin of our jugular foramen. It is very close in proximity. So it's not surprising that if you have a large lesion that involves the jugular foramen, it can also involve the hypoglossal canal and cause hypoglossal palsy. A very easy way of identifying where the hypoglossal canal lies on coronal imaging is depicted in this particular picture. So if you imagine this to be the lateral profile of the bald eagle, and this to be the beak, this is the head and this is the neck, the hypoglossal canal lies right under the neck of the bald eagle, or right exactly where the neck meets the head of the bald eagle. So that's an easy way of remembering where the hypoglossal canal is, because often it can be difficult to trace on axial images. Within the neck though, you cannot really see these nerves whether you do CT or MR, but you need to know that they are closely contained within the carotid sheath. So if you draw a line that goes around the carotid sheath that encircles the internal carotid as well as the internal jugular bulb, these cranial nerves tend to be clustered towards the posterior aspect. Now in the suprahyoid neck, you will find 9, 10, 11 and 12, but by the time you get to the level of the tongue, most of these nerves have disappeared except the 10, which courses way lower down. There are some important branches of these nerves that you also need to be aware of. You don't really need to know where exactly it is, but I'm just showing you these structures because you will hear this often. One of them is a nerve called the Jacobson's nerve. It's a division of the glossopharyngeal. How do I identify where the Jacobson's nerve is? You look for the internal carotid artery, you look for the internal jugular bulb, and look for a tiny canal between the two that kind of connects to where you will have the inferior part of the middle ear cavity. So this is called the inferior tympanic canaliculus. This is where the Jacobson's nerve lies. Why do we need to know this? Because this is a nerve that shows a predilection for glomus tumors to develop along its course. Similarly, you also have another nerve called the Arnold's nerve, which has a predilection for glomus tumors to develop. And in contrast to Jacobson's nerve, this is a slightly more laterally located nerve. So you again locate the internal carotid, you locate the internal jugular bulb, and you look for a tiny canal that connects the lateral part, which is the pars vascularis, to the facial nerve canal. So this is the mastoid canaliculus. So Arnold's nerve and Jacobson's nerve have predilection for glomus tumors to develop. The third nerve, which you are more likely to encounter in daily practice, is your recurrent laryngeal nerve. It's a branch of the vagus. And this nerve is extremely important because it supplies all the intrinsic muscles of the larynx, with the exception of the cricothyroid muscles. And it takes a slightly different course on both sides of the body. I'm sure most of us are already aware that the left nerve loops under the aortic arch through the aortopulmonary window. The right one loops under the right subclavian artery. And therefore, they take a slightly different course in their origin, but eventually both of them land up in the tracheoesophageal groove as they make their way more cranially towards their end organ. Now, how do these patients present with? Patients with cranial nerve 9 through 12 palsies, they can present with a variety of symptoms, including hoarseness of voice because the recurrent laryngeal or the vagus nerve is involved. It can be difficulty in swallowing due to vagus nerve involvement. You can have cardiac symptoms. You can have a mass-like lesion present in the tongue due to hypoglossal palsy, shoulder droop, or a combination of variety of these symptoms. But what is most important is for us to read from the clinical history where exactly they are suspecting the problem. That helps us determine what type of imaging needs to be performed. For example, if the clinical presentation tells us the lesion is more likely in the brainstem and skull base, we need to go to MRI right away. CT is not going to provide an answer. And when you do MR, you do need heavily T2 weighted KISS sequences or Fiesta sequences, as well as fat saturated post-contrast sequences. Doing a routine MRI brain and excluding pathologies, that is negligence. It's not really appropriate looking at cranial nerve pathologies. Similarly, if the clinical suspicion is that the lesion is not at the skull base, it is lower down in the neck, CT is a good modality to start off with because CT will provide you a good answer in a short amount of time, in contrast to MRI for the lower neck and the chest, which is prone to a lot of artifacts from vascular pulsation, swallowing, and cardiac pulsation as well. So CT is the workhorse if you think the lesions are lower than the skull base and in the neck and upper chest, whereas if you think the lesions are in the brainstem and skull base, you should start off with an MRI. Now let's look at some pathologies that can involve these nerves either separately or together. Let's start off with the brainstem. Here is a case that might look very similar to what Dr. Reed presented a few minutes ago. A patient presents with difficulty in swallowing and Horner's syndrome, and there is a lesion in the right posterior and lateral medulla. It does look like an infarct, and an infarct due to a right vertebral artery dissection. This is another patient who has a lesion on the left side, again shown on the diffusion weighted image to be an acute ischemic infarct. So both of these patients have acute infarcts in the posterior and lateral medulla due to a syndrome called Wallenberg syndrome. You did have a discussion about Wallenberg syndrome in a little bit of detail, so let me go through it one more time. It can involve portions of the spinothalamic tract or the spinal trigeminal nucleus, causing contralateral defects in problems in the body as well as pain and temperature is concerned. It can also cause ipsilateral loss of touch and pain in the face. But more importantly for this particular talk, because it involves nucleus ambiguous, it can cause difficulty in swallowing and hoarseness of voice. One very interesting finding that we need to remember is this can be associated with Horner syndrome because it involves the sympathetic fibers. Now, another area where you can get pathologies involving these nerves is the cisternal segment. So I'm going to show you a couple of pictures. A patient who presented with severe intermittent right throat pain. So again, if you trace these cranial nerves, remember this is either going to be the 9th or 10th cranial nerve. You find a nice prominent loop that is in close association with this nerve. So if you follow the same concept that you heard a few minutes ago in different talks, this is a type of vascular nerve compression that can occasionally involve the glossopharyngeal nerve. It's called glossopharyngeal neuralgia. The patients do present with intermittent pain in the back of the throat towards the palate or tonsils. This is again due to contact of the posterior inferior cerebellar artery with the glossopharyngeal nerve. Your heavily T2 weighted KISS type of sequence is going to usually provide the answer by showing that this nerve and artery are crossing at a right angle and the nerve itself is getting shifted by the artery. Again, this is a little bit rare compared to trigeminal neuralgia, but occasionally you will see this. Here is another patient presenting with multiple cranial nerve palsies and had a prior traumatic brain injury many years ago. Now, the pertinent finding here is the entire brainstem, cerebellum, and supratentorial brain appear to be coated with T2 hypointensity on gradient echo images. So the diagnosis here is straightforward. This is a patient with superficial siderosis. But what we need to remember is when you diagnose superficial siderosis, look into the clinical history because these patients might be presenting with cranial nerve palsies as well. And that's because the electrical conduction of many of these cranial nerves can be interfered with just hemosiderin deposition. Again, this is not easy to treat. There are various chelating agents that have been tried. So the importance is this can be associated with cranial nerve palsies. More commonly, you're likely to encounter lesions in the skull base and neck, so that's where we'll spend the rest of this talk. Here is a patient with pulsatile tinnitus showing a lesion in the right jugular foramen. This is bright on T1, shows heterogeneous signal on T2, multiple flow voids, and has intense post-contrast enhancement. So you can make the diagnosis that this looks like a vascular lesion, has the salt on T1 and pepper on T2 appearance. So this is going to be a jugular foramen paraganglioma. In contrast, this is another patient showing a lesion in the jugular foramen. It is not showing you that classical speckled appearance of a paraganglioma. The enhancement is a little more homogeneous and has a beautiful dural tail along the medial aspect. This patient actually had no cranial nerve palsies at all. So this was incidentally detected when the patient presented with left-sided headache. So this was not even on the same side as the headache. So this was a jugular foramen meningioma. And the third patient is obviously not going to be a paraganglioma or a meningioma because I'm going to show you the third companion case here. So this does superficially look like a meningioma but has some cystic areas. You can trace it along the long axis of one of the nerves here. So this turned out to be a jugular foramen schwannoma. Now the question beckons, can we distinguish these masses? To some degree we can. If you find prominent flow voids, salt pepper appearance, a moth-eaten osseous margin. So remember, CT is a useful tool in these instances. And intense enhancement, think about paraganglioma. If you find hyperostosis, such as a sclerotic margin, the lesion shows some calcifications on CT, has low T2 signal, and has a dural tail, think about a meningioma. And lastly, if the lesion has only a benign type of remodeling, has a spread pattern along the nerve, and shows cystic areas, think about schwannoma. In some instances, it's not easy to distinguish meningioma and schwannoma. So remember that these are just guidelines. They're not going to help you 100% of the time. Here is another patient who presented with a left-sided lesion. It does look like a mixed signal intensity lesion, shows intense post-contrast enhancement. It could be a schwannoma, but the important clue here is, where is this schwannoma exactly lying? Is this in the hypoglossal canal or is this in the jugular foramen? Look at the anatomy clearly. There is a jugular bulb that's opacified lateral to it. Also look at the end organ. If you see the end organ showing fatty changes, this is more likely a schwannoma arising from the primary hypoglossal nerve that supplies the left hemitongue. So this turned out to be a hypoglossal nerve schwannoma. There can be patients where multiple cranial nerve palsies present in a short amount of time, and this is such a patient who presented primarily with multiple cranial nerve palsies within 3 months. The first imaging actually shows an infiltrative appearing process with loss of fat planes, invasion of the clivus, invasion of the jugular foramen and hypoglossal canal. So this was biopsied. It turned out to be a nasopharyngeal cancer. So Depending on the acuteness of the history, you can have an infiltrative mass either be a neoplasm, and in some instances, if the acuteness is even more, within a week time, this can actually just be an invasive type of fungal infection. So the infiltrative nature doesn't really clinch the diagnosis here, but the clinical history plus the infiltrative nature should give you a clue towards the diagnosis. And moving away from the skull base into the neck and chest, there are some pathologies that you are likely to encounter involving these cranial nerves 9 through 12. Here are two different patients. This is a lateral projection of a carotid angiogram. This is a fat saturated T1 weighted image. Two different patients, both of whom have hoarseness of voice. The pertinent finding here is presence of a pseudoaneurysm in patient 1 and mural hematoma in patient 2. So remember, carotid dissections can cause hoarseness of voice if the dissection or the wall hematoma extends into the carotid sheath and involves the vagus nerve, which is lying along the posterior part of the carotid sheath. So dissection can be a cause of hoarseness of voice. Here is a more classical picture of an intensely enhancing lesion that kind of pushes the internal and external carotid arteries apart right at the bifurcation. So if you go to an MR, it shows flow voids. If you go to a conventional catheter angiogram, there is intense parenchymal blush. So this is a classical picture of a paraganglioma arising at the carotid body location. So this would be a carotid body paraganglioma. What I want us to understand is not everything that looks like a paraganglioma needs to be a carotid body paraganglioma. Here is a patient who has flow voids. Intense post-contrast enhancement is present. But you need to look at the displacement pattern of the blood vessels. So the internal and external are displaced medially. The internal jugular vein is displaced more laterally. So this is not really lying at the carotid bifurcation, and this is lying closer to the skull base. So this turns out to be a paraganglioma, but not a carotid body. This is a glomus vagali, because the vagus nerve is right between the carotid arteries as well as the internal jugular vein. So it tends to push these structures apart. Here is another patient with a similar lesion that has pushed the internal carotid and internal jugular vein apart, but it does not look like a paraganglioma. This is homogeneously bright on T2 weighted images, doesn't have a speckled appearance. So this would be a classical appearance of a schwannoma arising from the vagus nerve. So these are some entities which we often tend to confuse as part of routine clinical practice, but I'm trying to show you some clues to make the diagnosis. Again, something with salt and pepper appearance, more intensely enhancing. If it lies at the ECA-ICA bifurcation and causes splaying of those arteries, think of a paraganglioma. But if it has a similar imaging appearance and lies higher up, this could be a glomus tumor along the vagus nerve called glomus vagali. If you have a similar cystic necrotic appearance to what lesions you saw on the jugular foramen and has a spread pattern of pushing the carotid medially and jugular laterally, you're likely dealing with a schwannoma arising from the vagus nerve or any of the other cranial nerves that go along the carotid sheath. Here is a patient with recurrent squamous cell cancer where the cancer has invaded into the carotid sheath, has caused thrombosis of the internal jugular vein. In these patients, it's not difficult to make the diagnosis that it has infiltrated into the carotid sheath. You need a 270-degree angle of contact to make the diagnosis. But in these patients, they tend to present with multiple diffuse ipsilateral cranial nerve palsies as a result of invasion of the carotid sheath. So that is something to remember about. And we'll finish with these last cases. Here is a nice aortic aneurysm projecting into the aortopulmonary window with thrombus associated with ipsilateral vocal cord paresis, which is depicted by enlargement of the piriform sinus, enlargement of the laryngeal ventricle, medialization and thickening of the aryepiglottic fold, and a vocal cord that is pretty much medialized as well. So these are the classical appearances. Now why I'm pointing this out is this patient did not have hoarseness of voice. So based on how fast the vocal cord paresis actually develops, the contralateral cord can compensate. So you might be the first person to pick up that there is a vocal cord paresis on imaging and report that back to your referring provider. And once they go and look at the larynx on endoscopy, they might be able to corroborate your diagnosis. Here is another patient with a large thrombosed aneurysm of the aorta, again presenting with imaging findings of vocal cord paresis. So when I report these, I say, imaging findings are consistent with vocal cord paresis. Please correlate with direct laryngoscopic visualization because the patients might be totally asymptomatic. Now, I'm going to conclude here by saying that most pathologies involving the lower four cranial nerves involve more than one nerve, and therefore they tend to involve multiple types of clinical symptoms. So they are like 4 siblings who actually get along well with each other. It's rare, but it happens. So clinical localization prior to imaging is key because we can then help plan what type of imaging needs to be performed. If the clinical localization is to the brainstem and skull base, you start off with MRI. If it is in the neck and upper chest, you start off with CT. And remember that common tumors involving these nerves involve paragangliomas, schwannomas, and meningiomas, and that theme will tend to repeat itself over and over again. Thank you very much for your attention.